chapter 23, it's all about alcohols. So, ethanol, which is C2H5OH, is a sedative hypnotic drug and it is the most important alcohol of pharmacological interest. It has a few medical applications, but its abuse causes major medical and socio-economic problems. A very large fraction of fatal automobile accidents are associated with driving under the influence of alcohol, so under the influence or DUI. Other alcohols of toxicological importance include methanol and ethylene glycol. Several important drugs discussed in this chapter are used to prevent the potentially life-threatening ethanol withdrawal syndrome, to treat chronic alcoholism, or to treat acute methanol and ethylene glycol poisoning. So moving on to clinically important alcohols and their antagonists. So first we have alcohols, so ethanol, methanol and ethylene glycol. And drugs to treat alcohol withdrawal, so you have thiamine, and sedative hypnotics such as diazepam. And drugs to treat alcohol dependence, so you have disulfiram for dependence, and DNA basically, naltrexone and acamprosate. Okay, so dependence DNA, disulfiram, because diazepam is used in treating withdrawal, DW. So dependence DNA, disulfiram, naltrexone and acamprosate. And drugs to treat acute methanol and ethylene glycol intoxication, you have ethanol or fomepizole. So ethanol, after ingestion, it is rapidly and completely absorbed. The drug is then distributed to most body tissues, and its volume of distribution is equivalent to that of total body water, so 0.5 to 0.7 liters per kg. Two enzyme systems metabolize ethanol to acetaldehyde, and because these enzymes are essentially saturated by the large doses of ethanol commonly consumed, elimination follows zero order kinetics. So elimination of ethanol, zero order. So alcohol dehydrogenase or ADH, this family of cytosolic NAD dependent enzymes found mainly in the liver and in the gut accounts for the metabolism of low to moderate doses of ethanol. Because of the limited supply of the coenzyme NAD+, the reaction has zero order kinetics, resulting in a fixed capacity for ethanol metabolism of 7 to 8 grams per hour. So gastrointestinal metabolism of ethanol is lower in women than in men. Genetic variation in ADH affects the rate of ethanol metabolism and vulnerability to alcohol use disorders. And then other than alcohol dehydrogenase, you have microsomal ethanol oxidizing system or MEOS. So at blood ethanol levels higher than 100 milligrams per deciliter, the liver microsomal mixed function oxidase system that catalyzes most phase 1 drug metabolizing reactions contributes significantly to ethanol metabolism. Chronic ethanol consumption induces cytochrome P450 enzyme synthesis and MEOS activity. This is partially responsible for the development of tolerance to ethanol. The primary isoform of cytochrome P450 induced by ethanol 2E1 converts acetaminophen to a hepatotoxic metabolite. So acetaldehyde formed from the oxidation of ethanol by either ADH or MEOS is rapidly metabolized to acetate by aldehyde dehydrogenase, a mitochondrial enzyme found in the liver and many other tissues. Aldehyde dehydrogenase is inhibited by disulfiram and other drugs, including metronidazole, oral hypoglycemics, and some cephalosporins. Some individuals, primarily of Asian descent, have genetic deficiency of aldehyde dehydrogenase. So after consumption of even small quantities of ethanol, these individuals experience nausea and a flushing reaction from accumulation of acetaldehyde. Because some Asians have a genetic deficiency of aldehyde dehydrogenase, they kind of their face kind of becomes red as if they're blushing, and it kind of becomes shiny when they drink alcohol because ADH is deficient. Moving on to some high yield terms to learn. Alcohol abuse is an alcohol use disorder characterized by compulsive use of ethanol in dangerous situations, such as during driving or when combined with other CNS depressants or despite adverse consequences directly related to the drinking. Dependence is a disorder characterized by alcohol abuse plus physical dependence on ethanol. Alcohol withdrawal syndrome is a characteristic syndrome of insomnia, tremor, agitation, seizures, and autonomic instability endangered by deprivation in an individual who is physically dependent on ethanol. And delirium tremens or DTs. So it is a severe form of alcohol withdrawal whose main symptoms are sweating, tremor, confusion, and hallucinations. Then we have fetal alcohol syndrome. So it is a syndrome of craniofacial dysmorphia, heart defects, and mental retardation or intellectual disability caused by the teratogenic effects of alcohol consumption, especially ethanol consumption during pregnancy. Then Wernicke-Korsakoff syndrome, we studied about this in biochemistry last year. So it is a syndrome of ataxia, confusion, and paralysis of the extraocular muscles that is associated with chronic alcoholism and thiamine deficiency, B1 deficiency. Moving on to the acute effects. Before moving on, let us just look at this metabolism of ethanol by alcohol dehydrogenase family and the microsomal ethanol oxidizing system. So you have ethanol here, CH3CH2OH or C2H5OH. So it is converted to acetaldehyde, which is then converted to acetate by aldehyde dehydrogenase. Disulfiram inhibits this enzyme aldehyde dehydrogenase, and some people have a genetic deficiency of aldehyde dehydrogenase due to which, especially Asians, so due to which they flush when they drink alcohol. And then so basically MEOS kind of converts this to acetaldehyde, and it is an NAD pH dependent reaction. Alcohol dehydrogenase is an NAD plus dependent reaction, and fomepizole inhibits this here. So the acute effects, the CNS effects, major acute effects of ethanol on CNS are sedation, loss of inhibition, impaired judgment, slurred speech, and ataxia. In non-tolerant persons, impairment of driving ability is thought to occur at ethanol blood levels between 60 and 80 mg per dl. Blood levels of 120 to 160 mg per dl are usually associated with gross drunkenness. Levels greater than 300 mg per dl may lead to loss of consciousness, anesthesia, and coma, sometimes with fatal respiratory and cardiovascular depression. Blood levels higher than 500 mg per dl are usually lethal. Individuals with alcohol dependence who are tolerant to the effects of ethanol can function almost normally at much higher blood concentrations than occasional drinkers, although the acutely lethal concentration is not elevated as much. Additive CNS depression occurs with concomitant ingestion of ethanol and a wide variety of CNS depressants, including sedative hypnotics, opioid agonists, and many drugs that block muscarinic and H1 histamine receptors. The molecular mechanisms underlying the complex CNS effects of ethanol are not fully understood. Specific receptors for ethanol have not been identified. Rather, ethanol appears to modulate the function of a number of signaling molecules. It facilitates the action of GABA at GABA A receptors, inhibits the ability of glutamate to activate NMDA receptors, and modifies the activities of adenylyl cyclase phospholipase C and ion channels. And on other organ systems, ethanol, even at relatively low blood concentration, significantly depresses the heart. Vascular smooth muscle is relaxed, which leads to vasodilation, which in cold environments causes marked hypothermia. So moving on to the chronic effects, there is tolerance and dependence. So tolerance occurs mainly as a result of CNS adaptation to a lesser extent by an increased rate of ethanol metabolism. There is cross tolerance to sedative hypnotic drugs that facilitate GABA activity, such as benzodiazepines and barbiturates. Both psychological and physical dependence are marked and constitute alcohol use disorder or alcoholism. Liver. Liver disease is the most common medical complication of chronic alcohol abuse. Progressive loss of liver function occurs with reversible fatty liver progressing to irreversible hepatitis, cirrhosis, and liver failure. Hepatic dysfunction is often more severe in women than in men, and in both men and women infected with hepatitis B or C virus. GIT, so irritation, inflammation, bleeding, and scarring of the gut wall after chronic heavy use of ethanol and may cause absorption defects and exacerbate nutritional deficiencies. So chronic alcohol abuse greatly increases the risk of pancreatitis. Then neurologic, you have peripheral neuropathy, which is the most common cause of most common neurological abnormality in alcohol abuse. More rarely, thiamine deficiency along with alcohol abuse leads to Wernicke-Korsakoff syndrome, which is characterized by ataxia, confusion, and paralysis of the extraocular muscles. Prompt treatment with parenteral thiamine is essential to prevent a permanent memory disorder known as Korsakoff psychosis. And endocrine system, you have gynecomastia, testicular atrophy, and salt retention, which can occur partly because of altered steroid metabolism in the cirrhotic liver. Then cardiovascular system, so excessive chronic ethanol use is associated with an increased incidence of hypertension, anemia, and dilated cardiomyopathy. Acute drinking for several days or binge drinking can cause arrhythmias. However, the ingestion of modest quantities of ethanol raises serum levels of high density lipoprotein cholesterol and may protect against coronary heart disease. So, fetal alcohol syndrome, ethanol use in pregnancy is associated with teratogenic effects that include mental retardation, most common. So, the growth deficiencies, microcephaly, and a characteristic underdevelopment of the midface region. And neoplasia, so ethanol is not a primary carcinogen, but its chronic use is associated with increased incidence of neoplastic diseases in the GI tract and a small increase in the risk of breast cancer. And immune systems, so chronic alcohol abuse has complex effects on immune functions because it enhances inflammation in the liver and pancreas and inhibits immune function in other tissues. Heavy use predisposes to infectious pneumonia. So, moving on to the treatment of acute and chronic alcoholism. So, excessive CNS depression, acute alcohol intoxication is managed by maintenance of vital signs and prevention of aspiration associated with vomiting. Intravenous dextrose is standard. Okay, so thiamine administration is used to protect against Wernicke-Korsakoff syndrome, and correction for electrolyte balance may be required. So, intravenous dextrose is standard, and you also give vitamin B1 or thiamine administration to protect against Wernicke-Korsakoff syndrome. Then, alcohol withdrawal syndrome in individuals physically dependent on alcohol. Discontinuance can lead to a withdrawal syndrome characterized by insomnia, tremor, anxiety, and in severe cases, delirium and life-threatening seizures. Delirium tremens, basically DTs. So peripheral effects include nausea, vomiting, diarrhea, NVD, and arrhythmias. The withdrawal syndrome is managed by correction of electrolyte imbalance and administration of thiamine and a sedative hypnotic. Long-acting benzodiazepine such as diazepam is preferred unless the patient has compromised liver function, in which case a short-acting benzodiazepine with less complex metabolism such as lorazepam is preferred. Next, moving on to the treatment of alcohol use disorder. Alcoholism is a complex socio-medical problem characterized by a high relapse rate. So, several CNS neurotransmitter systems appear to be targets for drugs that reduce the craving for alcohol. The opioid receptor antagonist naltrexone has been proved to be useful in some patients, presumably through its ability to decrease the effects of endogenous opioid peptides in the brain. A long-acting depot preparation of naltrexone is approved for once monthly administration. Several antidepressants have been reported to reduce alcohol craving in small studies, but they are not approved for this indication. Acamprosate, an NMDA glutamate receptor antagonist, is also FDA approved for treatment of alcoholism. So DNA, disulfiram, naltrexone, and acamprosate in alcohol use disorder. So the aldehyde dehydrogenase inhibitor disulfiram is used adjunctively in some treatment programs. If ethanol is consumed by a patient who has taken disulfiram, acetaldehyde accumulation leads to nausea, headache, flushing, and hypotension, such as seen in Asians with a congenital deficiency of aldehyde dehydrogenase enzyme. Other alcohols are methanol, which is wood alcohol, is a constituent of windshield cleaners and canned heat, and it's sometimes ingested intentionally. Intoxication causes visual dysfunction, gastrointestinal distress, shortness of breath, loss of consciousness, and coma. Methanol is metabolized to formaldehyde and formic acid, which causes severe acidosis, retinal damage, and blindness. The formation of formaldehyde is reduced by prompt intravenous administration of fomepizole, inhibitor of alcohol dehydrogenase or ethanol, which competitively inhibits alcohol dehydrogenase oxidation of methanol. So, when you know a person has consumed methanol, immediately give ethanol or fomepizole, which are competitive inhibitors. Sorry, ethanol is a competitive inhibitor, and fomepizole is an inhibitor of alcohol dehydrogenase. Next, ethylene glycol. So, industrial exposure to ethylene glycol by inhalation or skin absorption or self administration by drinking antifreeze products leads to severe acidosis and renal damage from the metabolism of ethylene glycol to oxalic acid. Prompt treatment with intravenous fomepizole or ethanol may slow or prevent formation of this toxic metabolite. In this figure, you can see the oxidation of ethylene glycol and methanol by alcohol dehydrogenase, which creates metabolites that cause serious toxicity. So, ethylene glycol is oxidized to oxalic acid, which further causes acidosis and nephrotoxicity, and methanol is oxidized to formaldehyde and formic acid. So, it causes severe acidosis as well as retinal damage, renal and retinal damage respectively. Fomepizole inhibits alcohol dehydrogenase. Again, ethanol is a competitive inhibitor. That is all about this chapter.